and that's how you'll be seeing it on top of your screen that it is being recorded now. Thank you so much, Ramsunder. Please go ahead.
Okay.
Yeah, with that, I would like to hand over to Captain Jeet Kaur. It's all yours, sir.
Thank you, Ramsundar. Good evening, ladies and gentlemen. My name is Jeet Kaur, and on behalf of FCCRS, that is Foundation for Children Cancer Research and Support, and also Samundar Club, it is my privilege to present Dr. Kaur and Dr. Priyanka Sen, MD. Dr. Priyanka Sen will be presenting a brief overview of the heart disease prevention and also touch upon evolving body of knowledge on the effects COVID on the cardiovascular system. Right after the presentation, Dr. Kaur and Priyanka Sen will be there to take your questions. So please keep your microphones on mute, please. And during the presentation, you may send your questions over the chat box. They will try to answer them in the order they are received. Now, a little bit about Dr. Priyanka Sen, MD. She has been a very bright kid right from the start. She has never stood second. That means she has always been first in her class. Graduated as a valedictorian from her class. She's been a regional spelling bee champion. Bachelor's degree in biomedical engineering from prestigious Rice University. Medical school from Baylor College of Medicine. After 3 years of residency at Baylor, she was selected to do her cardiovascular fellowship at the world famous Texas Heart Institute. She did another fellowship in advanced heart failure at the heart failure and heart transplantation at McGovern UT School of Medicine. As if that was not enough, she did an advanced fellowship in interventional heart disease at Texas Heart Institute. After finishing this hard, grueling years of training, she was fortunate to be appointed as a teaching faculty at the world famous Texas Heart Institute and Baylor College of Medicine. She sees patients in both CHI St. Luke's and Methodist Hospital at the Texas Medical Center, Houston. And I'm so proud that she's my niece. Now about Dr. Biswajit Kaur, who is the chief cardiologist at Memorial Hermann Hospital Medical Center. He's a professor at McGovern Medical School, Interventional Cardiology, Advanced Heart Failure. Many of you know him, and those who don't, check out his profile, which is several pages long. So I won't spend time going over it. And yes, he's my younger brother. So now over to Dr. Priyanka Sen, who will do the presentation. Dr. Kaur will be also there to take your questions. So over to Priyanka Sen.
First off, good evening, everyone. I know few of you, I've met some of you as I was growing up. I think GP Uncle, I know you, and Neelam Auntie, we've all met before. So, but I'll start here. Let me just get this going.
Can this see?
Thanks again for logging on a Sunday. And the goal of my talk, again, as was mentioned, is to sort of go over preventive cardiology. I hope, prevention is always better than cure. And to that extent, there are some modifiable things that we can work on before you have a need, to go in for an emergent procedure or whatnot. So let's start here. So today's talk is on cardiovascular health, and now is the time to own it. So as you know, probably the growing epidemic of cardiovascular disease, many studies have shown this, epidemiological studies, that, of the things that tend to claim lives, heart and circulatory disorders take front and center stage. That's topmost, followed by cancer, then respiratory disorders and other organ systems thereafter. Accidents come very far on the list. But heart and circulatory disorders almost comprise the sum of cancer and respiratory disorders combined. I think it really sort of hits home for a lot of people, or rather was quite striking with the most recent news of
Priyanka?
Yes.
You're getting a lot of disturbance. Is it coming from your microphone? Everybody else is muted. Is it a little better? And we are not seeing your screen also at this time.
Oh, you're not? Okay.
No, we're not.
Let me go back.
Yes.
I thought I had shared it, but maybe I hadn't. Oh, yes, you're right. I had not shared it.
Go over it again.
Are you able
Yes.
to see it? Okay.
Yes. And if you can convert it now to present, yes, that's the one. Awesome.
Okay.
Thank you.
Oh,
I'm sorry to disturb you,
I'm
but
a
thanks.
softer spoken, so I'll come closer to the microphone here. But basically just going over what I said, that cardiovascular diseases are kind of topmost in terms of diseases that claim lives. And this is a worldwide phenomenon of it increasing in frequency. I just brought up this because this is pretty recent news, and I think when most people think of cardiovascular disease and whom it might strike, the idea of somebody who spent their entire life in sports is not really the picture they have in mind. And so that really gets people to start thinking that there must be something about our community that goes beyond what we look like on the outside or necessarily how much exercise we do, that predisposes us to this level of disease that sets us apart from other ethnic groups. And so a lot of more recent studies have been looking into this and over the last few years, because a lot of the population-based studies that have been done in the US have looked at ethnic groups that are more common here. And we're a quick growing minority in the US. So much so that the American College of Cardiology, that along with American Heart Association, which is the biggest organization here in the US for cardiovascular health, they actually had a feature on this. I mean, the cover you can see with the tapestry, Indian tapestry, was actually showcasing the increased occurrence of cardiovascular disease, not only of the heart, but including strokes among people of our ethnic group. And it's staggeringly high numbers when you look at it, that South Asians make up 25% of the world's population, and yet they comprise 60% of the world's heart disease patients. So something is going wrong. Heart disease is the #1 cause of mortality among Indians, as well as many other groups, but the so to speak, the proportions don't really work in our favor. And 50% of all heart attacks occur in Indian men. This is per one paper, in men less than 50 years of age. Frequently, the presentation among South Asians is about a decade earlier than it is in other people. And when we do end up looking, once these patients do present to the hospital, we frequently find that their arteries are more narrowed and of smaller caliber than their Caucasian counterparts. And they tend to have more diffuse disease such that it requires surgery. So it's a very different makeup of these patients. And when we finally look at what are some of the predisposing factors besides the ethnic group and genetic makeup, we also find that a lot of things that lead to the risk factors, such as diabetes, for example, are much more frequent in our community as well, such that we have 2 times higher rates of diabetes compared to Caucasians. So it's sort of back to a nature and nurture story. This is something that we always talk about when we're studying biology. It's true that we cannot change the cards that we're dealt with, and that includes things like genetics and family history. All of that's written in our DNA. But there are a lot of social factors, some of which that are under our control, that also happen to do with our quality of life. And so as you're running the rat race, all of these things in red sort of stack up. So psychosocial stresses, sedentary lifestyle, the need for convenience, and therefore an unbalanced diet that comes with it, increased work hours, lack of sleep, all of these things do contribute. In looking more at what sets us apart from other ethnic groups, there's been increasing awareness of what's known as a South Asian phenotype. And this is a picture of somebody from one such paper that was published in the Diabetes Journal. And I think most people would be familiar with at least somebody else who has this sort of body appearance. And it's just very common in our community, so that in spite of having a lower body mass mass index or BMI, South Asians tend to have this thin fat sort of phenotype where they look thin on the outside, but their markers on the inside mirror what it might be expected of somebody who's obese. So they've got central obesity, they've got visceral fat, more fat around their abdomen, which puts them at higher cardiovascular risk. They tend to be persistently inflamed. These are inflammatory markers. Their lipid panels, meaning their cholesterol panels, tend to be very deranged. And because of all of this, they tend to have increased susceptibility to getting diabetes, which in turn puts them at higher risk of having coronary artery disease. Is everyone able to hear, by the way, since I just...
Yes, it's loud
absolutely.
and clear.
Yes.
Thank you.
You know, going over, of course, what is God given to us, there are some things that are actionable items. So I want to spend the next few slides talking about that, because there are some things we can do to mitigate the risks that we're born with. Of those things, metabolic syndrome is first and foremost. Metabolic syndrome is really a term used to kind of encompass a lot of the other risk factors, such as deranged cholesterol, specifically elevated triglycerides, low HDL, which is the good cholesterol, increased waist circumference, which is where so many of us fall, where the fat tends to just accumulate at the abdomen, elevated blood pressure, and elevated glucose. This is a growing issue. Of all of these, probably the high blood pressure is the most common, but with the use of a lot of convenience stores and fast food chains and all of that, obesity is very quickly approaching and rivaling. Metabolic syndrome goes beyond those markers. It sets you at increased risk for many things, not only from the cardiovascular standpoint, which is the focus of our talk here, but increased risk of cancers, gynecological abnormalities, gout, fatty liver disease, many other things that go along with this. So basically where we go from here is to do age-appropriate screening. And for many of you, this should be taken care of by your primary care doctor. This is one example of a risk stratification score that we use. But basically, there are many others like this, but I'm just highlighting this one to show some of the factors that go into determining somebody's cardiovascular risk. ASCVD is what it stands for, which is atherosclerotic cardiovascular disease. These are the kinds of diseases in the body that are mediated by plaque formation that lead to blockages of your heart vessels or the vessels in your brain, leading to strokes. So things like age, so advanced age is a factor. The presence and the lack of control of diabetes. Gender plays a role. Race matters. In this one, as you can see, South Asians would get lumped into the other category, but as there's more and more studies, I think they will have separate categories for us because our needs are different. Whether or not you smoke, your total cholesterol, HDL, systolic blood pressure, and whether or not you're receiving treatment for high blood pressure. Based on this risk stratification, or just a sense about the patient based on all of this, clinicians will usually have a discussion before potentially having to start medications, but that's only to be preceded by lifestyle modifications. So starting with the first one, which is obesity, a lot of patients will come into clinic. There's this, I guess, lack of insight of their own body size and body shape and how that could have very harmful effects on their body. So this complaint of I'm just big bone, as you can see here, there's more to the story. Body mass index is one such marker that we can use as a surrogate for assessing somebody's level of healthy weight, but it too does not tell the full story. Body mass index, you can see, is calculated by your weight divided by your body surface area. And although the WHO does put different, ideally you want to stay in the green in this category. And while it does play a role, there are some things beyond it that matter. For example, two people, one who's very athletic and one who's not, with the same weight but the same height, might calculate to the same BMI, but they have very different body composition. And that's where South Asians really suffer in that way. The thin fat Indian, which I showed earlier, which is actually a term being used at this point, shows that even at the same BMI, we are functionally like somebody in a different ethnic group who weighs more than us. So that there are new BMI cutoffs for Asians and Asian Americans, so that where 23 would normally put you in a healthy range if you were Caucasian, now puts you in an above healthy range. This is just to raise awareness and get people to really start lifestyle modification earlier. And again, this has to do with the body composition, that Asian phenotype tends to have more fat composing the body. So the next thing to deal with is high blood pressure. And here the definition starts at over 130 by 80. And there are many risk factors that are associated and might predispose one to it. Of course, genetics, smoking, obesity, impaired sleep, sleep apnea, where people might snore a lot or have cessation of their breathing when they're sleeping, chronic kidney disease. There are some endocrine conditions, and there are some medications which sometimes can be stopped with reversible effects. For example, a lot of use of steroids or medications like ibuprofen, decongestants, these can also cause somebody to have higher blood pressure. So at the start of all of these risk factors, when we're trying to manage them, first and foremost is lifestyle modification by all of the medical community, medical teams. And the goal generally upon starting medications will be to try to get you to less than 130 over 80 if you're able to tolerate that. So basically when your blood pressure is measured, these are the different categories. It's not till you're in the elevated category of here, high blood pressure stage 1, that usually pharmacotherapy or medications are started. But at all of these stages, lifestyle modification is very, very important. And the goal is to control it before it leads to any irreversible complications. But there are non-pharmacological treatments that any one of you can start from today if you haven't already. And this is something taken from the American College of Cardiology just to show you some of the anticipated improvements that you can have in your blood pressure based on just simple things like weight loss, where 1 millimeter of mercury seems insignificant, but that's for every kg reduction in your body weight. A healthy diet, which focuses on more fresh fruits and produce, higher in potassium, lesser in sodium. This is the idea of what's called the DASH diet, more fresh vegetables and less animal proteins like Mediterranean diet, which many of you would have heard of. These are things that factor into here. In addition to which, exercise is very important. Specifically, aerobic exercises are very good for maintaining cardiovascular health. And we're just talking about moderate things, 90 to 150 minutes per week, and moderation in alcohol intake, which we'll talk about. And then the next thing that's modifiable potentially is hyperlipidemia. Usually people will describe it as the good and bad cholesterol. So the bad cholesterol being your LDL level, that's what is made by your liver and deposited into your, it's sent into your bloodstream. And that's the one in its most sinister effects is when it gets into your blood vessels and causes plaque formation. And then the good cholesterol, which is meant to fight that and maintain regulation.
Priyanka, I think you got muted. If you can just unmute yourself. Sorry.
Sure. Did I get muted at this slide or before? I'm not sure. Okay, so I'll just start over here. So with the cholesterol, again, there are two different types of cholesterol. We aim to lower the LDL as much as possible, and HDL, we try to raise that. Here are some examples of lipid goals. Of course, if somebody has already had exhibited cardiovascular disease, our goals would be more stringent than what are listed here. But for primary prevention, these are the numbers. If you have your own panel, you can compare to this. And the other thing to think about is that cholesterol does not just come into our bodies from just fatty foods. it's about having a balanced diet. So it's not just that you didn't eat ice cream and therefore your cholesterol panel is going to look great. Excessive carbohydrates is also going to affect your lipid panel in a bad way. So here are many things which seems to be a common theme, but the different things that are in your control and what you can do. And after all of this, I'm just going to branch out briefly. You know, there's a whole class of medications which some of you might already be on. These are all the medications that end in statin but are so commonly used. And there are many indications for this. If your LDL is already too high, if you already have diabetes, that's put in a category of itself, because diabetes can have such sinister consequences that it's already labeled as a coronary artery disease equivalent. So that's serious. Again, certain risk scores matter, and the risk is further enhanced if you have a strong family history, you have chronic kidney disease, certain inflammatory conditions, and certain ethnic groups, which is becoming more and more recognized. Being South Asian is actually a risk enhancer. And finally, for secondary prevention, if you already have cardiovascular disease, then certainly you will already be put on this medication. You know, I keep circling back to lifestyle modification because irrespective of what medications a physician might start you on, it's imperative that you still do your part in terms of your diet, your exercise, and all of that. And then the other one is diabetes, especially type 2, which is the one that is triggered by insulin resistance, which means that your body is not responsive to the effects of insulin, which is an enzyme released by your pancreas that is supposed to bring sugars back into your cells. When that doesn't happen, the sugar level in your bloodstream is chronically high. That can lead to increased inflammation, increased damage to vascular walls, leading to early plaque formation, and all of these things. When you have your diabetes check, this is part of the routine screening. And basically it's an assessment of what your average sugars have been for about 3 months. And based on that, you may or may not be asked to start medications. But diabetes in general, because it's resulting in high levels of sugar throughout your body, it can affect so many different organ systems. We're talking about stroke and heart attack as well as peripheral arterial disease today, but it can affect the eyes, the kidneys, peripheral neuropathy, all of these things. And finally, diet. Diet really matters. To some extent, you are what you eat. So we have to choose wisely.
That's a nice one.
So of course, you can see that in the evolution of man, you know, we started as probably hunters and gatherers at some point. I think a few generations ago, probably many families had you know, were more based in rural life, and now with increased urbanization, and this is a worldwide trend, and just having the availability of more food. It has some pros, but also has led to increasing obesity. You can even see that the size of the dinner plate has changed widely, and therefore a full dinner plate today in 2009 even has a significantly more, it's significantly more calorically dense than a similar plate in the 1960s. And what's funny, I just came across this while making these slides, is that these ungodly proportions, so to speak, have even translated into artwork. So the Last Supper was, you know, obviously very well-known painting, but in progressive renditions of this art, they've found, actually there was a study published in the Obesity Journal that showed that the plate sizes were increased and the contents were much more succulent and fuller. So clearly, you know, to the extent that art is a reflection of society, I think we can see that worldwide there's a trend to eat ourselves to death. So, you know, we obviously come from a lot of good culinary culture, and that makes it difficult to choose wisely, but also to some extent makes it easier, because even if people ask you to eat more vegetarian food, I would say that we have a lot more options than perhaps somebody who belongs to a different ethnic group. So we have to choose accordingly. I'm not a proponent of an elimination diet, but everything should be done in moderation. Because foods come at a price. And so, you know, the example of things that we're eating at convenience, you know, you're at party, you're just having some, peanuts or something with your drink, or you're having a bag of chips or something. These are very calorically dense foods. So we have to sort of decide where we want our calories to come from for the day if we're to maintain our weight. If 25% of your daily caloric intake gets exhausted by a bag of peanuts, you have to decide if that was worth it for you, because at the end of the day, you might not be full after that bag of peanuts. So avoid those types of foods if you can. Avoid drinking your calories, because that's a silent way of taking in nutritionally poor but calorically dense items into your body. Not all calories are the same. Just because you add up the labels to be the same doesn't mean they're all equally good for you, because your body stores them in different ways. And remember that for everything you eat, it takes 3,500 calories to lose 1 pound of body fat. So if you're willing to do that, then sure. And so some dietary strategies, as I said, complete elimination is not a great idea, because a diet that you can't follow is really not useful. But where you can, prefer home cooked meals to take out unprocessed foods. Try to balance it when you're doing carbohydrates, choose more complex carbs such as whole grains versus refined things. You might prefer to eat wheat-based chapatis or something as opposed to white rice. And there's so many alternative grains that have come out. Even with proteins, you would choose white over red meats, predominantly because, especially when you're eating animal proteins, they're also coming to you with fats. So there's a little bit less fat when you're eating it from white meat source. You might consider switching it up with some other types of protein sources. And fats, I would say, I think I've seen this happen a lot, but try not to reuse cooking oil. It does change the chemistry of it a little bit, such that it's worse for you. And then finally, alcohol consumption. I was asked to talk about this because I think this is a very party-going group here. So, alcohol consumption, there's good and bad. The good, obviously, it makes you relax, makes you feel really happy. It's a great thing to do on weekends. It may raise your HDL. There is some evidence out there in support of that, but everything is in moderation. And to be honest, if you're using it to raise your HDL and using that as the justification, there's a lot of other things you can do to raise HDL too. But, in moderation, alcohol is okay. The bad things, it can increase your triglycerides, it increases glucose level, increases fat stores, increases blood pressure time if it's done in excess, and therefore it can increase cardiovascular issues and chance of dependence. Here's a simple sort of a cartoon here that you can see some of the more commonly had drinks and what sort of unhealthy snacks would be comparable to it in terms of caloric intake. And you can see actually, even though wines actually tend to be more caloric, have more calories, even though wine is the one that, flavonoids and all this sort of thing that can be helpful in reducing inflammation. That's proponents of alcohol would say that. So I guess in trying to bargain with the group here, I would say if you drink something, consider a drink that packs the punch, but maybe with less carbs. So, if you're going to have whiskey or something like that, consider it instead of maybe a big glass of wine. That might be an option. I'm not saying that this is like with a seal of approval, but, we have to work with people.
Oh, hell.
Because size matters. Size does matter. You can see the ounces for these different things. Again, I repeat, moderation is the key. Whatever cardiovascular journal you may have come across or articles that are proponents of alcohol would say that moderate drinking is considered 1 or less drinks for women and 2 drinks or less in men per day. And there's a definition for the size of a drink as well. That would be 1 ounce, 1 12-ounce regular beer, 5 ounces of wine, which essentially put you at this red dotted line in a wine glass. And I'm not talking a huge goblet, a regular. I mean, you can go up to 10 ounces, say who cares, but that's the recommendation. And then of course, binge drinking in any form is probably just as bad as drinking heavily chronically. But like I said, there are many other ways to reap the same benefits, but of course, some ways are more fun than others. And then smoking, finally, I wanted to just touch on this because it is definitely a modifiable risk factor. Many people smoke. Over 16 million Americans have a disease that's somehow caused by smoking. It's not just cancer or heart disease, asthma, various things. And it's not just to the smoker, it's also the secondhand smoke inhalation by people around you. And again, the way it works, it causes oxidative damage to the blood vessels, which causes a lot of inflammation, increasing all of these things. And in general, life expectancy for smokers is at least 10 years shorter than for non-smokers. And just as a map of India, I don't know how many people are tuning in from there, but definitely there's a regional variation in the use of smoking, use of inhaled tobacco, a little bit more in West Bengal and East India, you can see here. So smoking used to be really cool. I think back when many of you all were my age, but at least 4 Marlboro men have died of smoking related diseases. So it's not as cool as it looked back then, I guess. And you can see here, smoking can be attributed to a lot of the causes of death. All the dashed lines are the percentage of each of these that were directly related or thought to be with smoking. And when you tabulate all of that, it's not insignificant. And this is as of 2005. So anytime is a good time to smoke. It's never too late. This is just something to get you motivated. If you are somebody who smokes, just 1 year after smoking, your risk of heart attack drops sharply. 2 to 5 years later, your risk of stroke may reduce to even that of non-smokers. In 5 years, your risk of several of these cancers can drop by half. And in 10 years, your risk of dying from lung cancer drops by half. So it's never too late to stop. And there are many strategies that your physician can use to help you if just stopping on your own is proving too difficult. And finally, sitting is the new smoking. It is almost just as bad. And unfortunately, we do it a lot just because sometimes our job requires it or we are just too lazy to get up. 1 in 4 Americans sit for greater than 8 hours a day, according to CDC. In 2011, there's a study that showed this, and you can see substantially increased risk of so many risk factors just from sitting. So I just say, please get moving. And moderate exercise, it doesn't take a lot for it to be good enough for your cardiovascular health. Of course, if you're trying to get into that outfit that you wanted to wear, a year ago, that might take more work. But basically, moderate exercise, brisk walking, 3 to 5 miles per hour, at least 3 to 5 times a week, averaging 150 minutes per week is probably enough. And the benefits are multifold. And these are some other things, even some home activities can get you some of these caloric, help you burn, but definitely if you do brisk walking, that's enough. And finally, I just have a couple slides here. Primarily this was to get you to know more about preventive strategies, but in the event of an emergency, just wanted to let you know, with heart attacks, it's every 40 seconds, somebody in the US is having a heart attack. That amounts to a lot of people annually. It's caused by acute occlusion or lack of oxygen-rich blood to the heart muscle itself, at which point thymus muscle starts dying. And it can present with symptoms of chest pressure, tightness, squeezing sensation in the chest. That's in its most typical form. It may spread to the jaw or neck or arm, but sometimes people, especially women, elderly, diabetics, they might not present in the same way. It might be less obvious, like just fatigue for no reason or indigestion with exertion. These may be harbingers of something worse. And what to do? Please call 911. Don't sit there thinking what it could be, waiting to try that antacid. If it's really that severe, you need to get called and just have it checked out, because time is muscle. And the goal of all our strategies here, like to stent to open a vessel, is to save the muscle so that you don't get complications like sudden cardiac death or heart failure. And just briefly about stroke, if you think about it, it's just like it's like a brain attack, a heart attack, but happening in the brain vessels. Again, it's also 1 in every 6 deaths from cardiovascular disease is actually due to stroke. And someone has a stroke quite frequently, almost like a heart attack. And again, time is of essence. And here we're talking about the brain. There's a mnemonic here, be fast, that I think everyone should be at least familiar with. The things to look out for: sudden lack of balance or loss of coordination, sudden blurry vision, disbalance of the face where there's asymmetry, sudden, weakness in the arms, impaired speech where it's like garbled speech, unable to get the words out. And when that happens, T for time. It's very, very important. Yeah. So that was most of the slides that I had here. I just leave it to any questions you might have for either one of us. And if there are any questions about COVID, I have some things here as well. If that
They didn't talk. Oh. I have a question.
Yes, Ms. Glockenberg.
How are you? Thank you so much for sharing. That was great. So I just have a question about cholesterol.
Okay.
My cholesterol was recently 230. When do you think a person should start on statins? Like, what is I know it's not just cholesterol, but my blood pressure is good. Overweight, definitely. And my cholesterol has recently gone up. So what is the magic number that somebody would start? Is it a statin?
Yes, it is a statin. And, the total cholesterol, of course, is a number that we look at, but also the breakdown of that. Specifically LDL, which was the bad cholesterol that I was mentioning earlier, because that is what leads to the plaque formation here. And that's what we're trying to prevent with use of things like statins. So like I mentioned, if that LDL is greater than 190, that already is a reason for somebody to be started on a statin. But in addition to which, if you have other risk factors like advanced age,
What do you
high
think
blood
advanced
pressure.
age? What should
Well,
say?
40 to 70 is what the study is based on, and it's sort of it goes linearly with that. So the older one is, the more risk they're at. But
So wait, to get back to my question,
Yes.
seriously.
Laurie, can I bother you for a moment? So we have lots of questions and we still have Dr. Carr to say. So if you have a question, if you can type it in, it'll make it easy. We have 88 people and there are lots of questions at this time.
Okay.
So thank you. Dr. Carr, would you like to comment?
Yes, like Priyanka said, it's just not a number. Yes, the only number is 190 bad cholesterol LDL. That is a type of genetic disorder where you have to start statin, otherwise you'll have devastating complications down the line. It can be started as early as age 20 or 25. These are typically families where having heart attacks at the age of 35 or 30 and sudden cardiac deaths. So it's a very unique subset. For the vast majority, there are a lot of risk calculators out there for your 10-year and 20-year risk of coronary artery disease. There are composite scores. There's some, she mentioned Framingham score, there's a PEC score, there's a Reynolds scores, there's a Bernardine score, and all those other scores which are there. You can use any one of them. And if your score is more than 7.5% risk in 10 years to develop coronary artery disease, then you should be on a statin. Now, exclusions are people who have diabetes. They don't have to be 7.5%, as diabetes is classified as a vascular disease. Or if you have kidney disease, but the GFR is more than 15, there is no safe data in patients on dialysis, but patients who have CKD or have more than 2 risk factors. Basically, if you have an intermediate risk of developing coronary artery disease based on your risk factor profile, you should be on statin irrespective of the number. Now, we are talking about 2 use of statin. One is a primary prevention. That means you don't have coronary artery disease, you just have the risk factors. That is what I just talked about. The second one is a secondary prevention, that you already have coronary artery disease, or you've had a heart attack, or you've had a stent, or a stress test which was proven that you have underlying coronary artery disease, then universally you should be on a statin. Now, there are two other groups who are at very low risk, who just by the scoring are low, but they have a family history which is intermediate. There, the recommendations are to do some more enhanced testing, could be genetic testing, ApoB, lipoprotein A, or some fractionations, or calcium coronary, to decipher whether this is on the low intermediate range or a high intermediate range. And anyone who's at high intermediate range should be on a statin. So it's a long answer for a simple thing, that for familial cholesterolemia, you should be taking statins. And for everyone else who has a risk factor more than 7.5%, 10-year projection should be on a statin. And every person for secondary prevention of heart attacks, that means you already have coronary artery disease, should be on statin.
Hi, Dr. Carr. Monitoring the chat, we had someone asking about tips for managing angina.
Okay. Tips of angina basically is a cry of a heart muscle which is not getting enough oxygen. That is the warning signal that you have. Having said that, you have to be mindful that certain conditions, especially like diabetes, where nerves, which are the smoke signals, are damaged, you may not have any angina and still have significant coronary artery disease. Although typical definition of angina is someone who's having substernal chest pain brought on by exertion, relieved by rest and nitroglycerin. But now American College of Cardiology is moving away for that diagnosis because it just could be a discomfort. It doesn't have to be pain. Many patients come to us and say, I don't have pain. Just a little chest heaviness or chest tightness is angina. So basically, if you say there is angina, you're saying that your heart muscles, you don't know which part of the heart, but the heart muscle is not getting enough oxygen. That could be a function of two things. Either there is decreased supply or there is an increased demand. Increased demand is in a condition, for example, your heart is overworking and there are blockages and it cannot meet the demands of the oxygen requirement of the muscle. There you have to improve the oxygen content of the blood. For example, if somebody is severely anemic, your hemoglobin has gone down to 7, you need more oxygen. That hemoglobin. On the other side, if you have blockages more than 70% in your coronary arteries, that starts impairing blood flow. It may be comfortable at rest, but when you exercise and the oxygen demand goes up 3 or 4 or 10 times, it is not able to augment it proportionately. There you have to increase the supply by opening up that artery. That is called revascularization. Either you do it with a stenting or you do with bypass. Having said that, if you have mild angina, which is predictable, you have to define two types of angina, which is critical. One is called a chronic stable angina. That means the frequency, intensity, or duration of that chest pain or discomfort is very predictable. You can say, Dr. Carr, whenever I walk after half a mile, I get this discomfort. I sit down for 15 minutes, goes away, and then I can walk. It is very predictable and goes away. That is chronic stable angina. Their medicines are as good as any revascularization. You really don't need to go for stenting or bypasses. If you use a little nitroglycerin, if you use a little beta blockers, medicines which decrease the oxygen requirement of the muscle, control your blood pressure very well, take the statins, decrease the cholesterol to avoid further buildup, and take an aspirin tablet so that the blood doesn't clot there and it's a little thin, that'll be good enough. But the more sinister one is called an unstable angina. Unstable angina, by definition, is angina or chest discomfort, which happens either it's a new onset, that means less than 2 weeks. It is increasing in frequency, intensity, or duration. That means it's changing the character of your chronic stable angina. Or if it is lasting for more than 15 minutes, even after taking nitroglycerin, you pop 2 nitroglycerin, the pain is still there, but 6 months ago it was going away, but now it's not going away. Or if you start having rest pains, that means you're not doing anything, and yet you're having this chest discomfort. These are warning signs. If you don't do anything, 30% of this in the next 6 months will have a major heart attack. So these require immediate attention, and you need to call your physician or go to the emergency room and get treated immediately, because you don't want it to progress to a full-blown heart attack where you will lose the muscle. Because if muscle dies, it doesn't regenerate. There is stem cells and all those things on the horizon, but right now we have no therapy to bring back a muscle which is dead.
So you have to preserve your muscles. So make a clear distinction in your head between chronic stable angina and unstable angina. Stable angina is an emergency. Chronic stable angina is a much more benign condition which can be treated by medicines.
Another question is, what should children do to prevent juvenile heart problems and diabetes?
That's a very broad question. What should the children do should be not different from what the adults do. In fact, the latest data suggest that the type 2 is an epidemic. Type 1, unfortunately, is not an environmentally controlled disease. Type 1 diabetes is something which you either have your insulin cells damaged, and that is a very different beast, and that has to be treated with insulin, and you have to keep your blood sugar levels very well controlled to prevent any macrovascular complications over the years, which includes the eye, the kidney, the heart, and the brain, and the legs. So that's a different beast, and we are not talking about that. But type 2 diabetes, the obesity in children, is an epidemic. The pediatrics department has already mentioned that. And that is because of many factors. You know, the American diet has, from compared to 1970 to now 1996, has gone up 20% on its caloric requirement. That means you're now consuming 425 more calories than your peers who were taking it in 1970. Number two, the fast foods are heavily engineered, made very tasty, heavily promoted. An average child sees 10,000 advertisements of food-related products to be sold on the television in 1 year. Can you imagine that staggering number? How much promotion is going on? And then the average snacking rates have gone up by about 70% in children. Inadvertent snacking, they're playing video games, they're watching a television, and they're eating. Now, just think of the balance. I'll give you a few examples. 100 calories. 100 calories is burned by 12 minutes of running, 30 minutes of jogging, 1 hour of walking, or 3 hours of watching television. And you know, it takes 53 peanuts to give you 100 calories, half an apple, 1 slice of bread gives you the equivalent. So you can see this table and you can see how hard it is to burn the calories that you've taken. Unless you control the intake, you will not be able to burn the calorie. If you think I'm going to eat what the hell I want and go to the gym and burn, good luck. You cannot do that. It is impossible. I'll give you a very simple example. If you take an average male, he has to take about 2,000 to 2,200 calories. But do you feel like just having a half a glass of apple juice? Just 100 calories, 5%. If you just take that, you will gain more than 10 pounds in 1 year, just doing that part. The converse of this is, instead of taking the stairs, you take the elevator and you burn 100 calories less 1 day, which is nothing. Instead of 3 flights of stairs, you take the elevator, you will gain 10 pounds of weight in 1 year, because it takes 3,500 calories to make 1 pound. So you can do your math. It is very simple. It's a supply and demand, calorie in and calorie out. So it starts with education of your child, preventing those advertisements, the heavily marketing that goes on, the easy availability of fast food. And some of the tips you can do when you take them to a restaurant, you use a small plate. If you, whatever food they supply in restaurants these days, cut it in half, take half to home and just eat half. And in any plate, put 50% of the plate should be covered by veggies, 2/3 by proteins, and only 1/3 by carbohydrates. Do not watch television or movies while you're eating, because inadvertent eating will add 25% more calories to what you eat. And then promote healthy education about physical activity, which Priya already said, I'm not going to repeat it. But the need of the hour is bring back the mom in the kitchen. That's what needs. You need to eat fresh, made, balanced food. If you keep going and eating out and eating in the fast food restaurants, it'll never get better. There is an old Chinese saying, it's every feast will eventually come to an end. Because we are all born with genes when we were hunter-gatherers, which is called the thrifty gene, which accumulates every energy you get to be used at a time when there is a famine. But in the last 100 years, we have not had any famine. So that famine will never come and this feast will end, and that will not eat well. So it is very important that the supply and demand side of food is managed very well in your children. And the sooner you can inculcate this in them, better it is there for the long-term prognosis. Changing your food habits later on when it's established is one of the most difficult things that you can do. And one thing I need to add here is if you take one beverage, sweet beverage every day, you increase your cardiovascular mortality by 23%. Just one sweet beverage, one Coke, one Fanta. And there's a misnomer out there that if you take artificially sweetened fluid, the Diet Coke and the Zero Coke, those will reduce the calorie intake. Certainly it will reduce the calorie intake, but it will definitely increase stroke by 28%. So those are safe, and that's why those should be banned as well. And the last thing, because you're talking about childhood, try to see they're not going into e-cigarettes. E-cigarettes have a lot of complications, cardiovascular and pulmonary and otherwise. And you need to train them and protect them from e-cigarettes. So these are some of the things that you can do to educate and guide them properly and try to get them a healthy lifestyle from the beginning, which becomes their habit. And then you don't have to try to modify them later.
A couple questions that seem to be kind of related. One question was, if someone has a parent that had a mini stroke, does that make their children or them more at risk? And then also, if they had a sibling that had blocked arteries, does that mean that they're automatically at a higher risk?
Yeah, to take that.
Well, certainly there are genetic predispositions to having atherosclerotic disease, and especially some of the risk factors that led to it that I discussed before. So actually, when we are assessing somebody's risk for having cardiovascular disease and an MI, which is a heart attack, we do ask about early or premature family history disease also. So that is significant. I think it definitely warrants closer screening and monitoring of all these modifiable risk factors early on.
Great. So the genetic impact that you're asking about, what is your predisposition, is based on two things. If you have this familial hypercholesterolemia gene, that is, of course, adds a lot of risk, and that usually presents in your family members as sudden cardiac death or early coronary artery disease below 35. But in your family, if someone has developed a coronary artery disease, in females and males are different. If your father's side or your immediate sibling had developed coronary artery disease less than 55 years of age, and mother or the female side has developed coronary artery disease less than 65 years. And when I say coronary, it's vascular disease. Coronary and stroke go very parallel because it's the same disease process. If you have that, then again, you are at a definitely higher risk of developing those diseases. And then if you have other conditions which are inheritable, like the type 2 diabetes, which I mentioned, if you have that, or if you have hypertension, those are modifiable risk factors, then again, you have at a higher risk of developing these things.
How does COVID change the risks, and what is observed? What are the observed effects on cardiovascular health with COVID?
That's a very good question, but it's an evolving question. Let me preface that by saying that there is not a single COVID expert. We are all learning on the job right now, and COVID is teaching us valuable lessons every day. So whatever I say is based on personal experience, anecdotal experience, and whatever is published, which by no means is comprehensive. Now, in the COVID, it's a multi-system disease. It's unlike many people think COVID is a respiratory disease, that it affects the lung. It's a misnomer. It is a vascular disease. It affects the inner lining of the blood vessels in the entire body. And the presentation is from the brain to the toe. You can have inflammation. But the predominant 77% of the deaths is because of the pulmonary complications. Small little clots form in the lungs, which cannot then oxygenate. You go into respiratory failure. But the severe decrement in the oxygen levels in your body, the severe inflammation cascade, which is activated by this virus, and also the virus invading your heart muscle cells, and the drugs like chloroquine and others, which have been used to treat empirically the COVID treatment, have all conspired to cause significant cardiac illness also. And all four presentations of heart has been seen. Number one is that it's an innocent bystander and there's some inflammation in the outside of the heart which resolves. Number two, the pump goes into failure, causing fulminant myocarditis that happens mercifully in 7% of the patients as a cause of death. Number three, it can present like a pseudo heart attack. Your EKG shows that you're having a heart attack, but actually it's your small vessels, not the big vessels of the heart. They get plugged up by small clots which are formed inside. And number four, sudden cardiac death, because the way the cells are affected, it can go into an electrical storm, which can kill you suddenly. So all four presentations have been known. But the more scary element is based on papers which are coming out now. There was a paper where they took 26 athletes, all of which had just mild symptoms or no symptoms at all, who were COVID positive, and they went back to start playing the games, and they had an MRI. 46% of them had MRI evidence of cardiac involvement. It's a scary thought. They are doing competitive sports. The sudden death rate would be so much higher. But even more sinister is a paper which showed that out of 100 consecutive patients with COVID, 33% of which were hospitalized and the rest were not hospitalized, but at home, 71% of them had MRI evidence of cardiac involvement 71 days after discharge or 71 days after complete cure. What does that mean for the future? If this virus has caused effects in the heart muscle, which is even persistent more than 2 to 3 months after your initial insult, this may translate, may is the word, I hope God saves us, this may translate into an epidemic of heart failure in months and years to come. It will slowly go down and cause a pump failure. As you know, most of the heart failure diseases, if you don't have blockages and you don't have a heart attack, called the non-ischemic cardiomyopathies, are because of some remote viral infection or some genetic predisposition. And if this happens to be a remote viral insult, and you know the staggering numbers of people who are infected, and if this is the prevalence of the virus effect of the heart, we are just, in the cardiology community, are just nervous what's going to hit 5, 10, 15 years from now. So yes, COVID is a very serious illness. It can kill you suddenly, but even if you survive, you're not out of the woods. You have to go for regular checkups and keep a very close follow-up. Do not neglect any symptoms. Heart is in the center of the way it's involved, because endothelium, which is the inner covering of all the blood vessels, which originates from the heart and everywhere, is the primary target of this virus. And that is a big problem. And we don't have amazing therapies yet. Many therapeutics are coming out. But right now, the only thing which has made any dent is social distancing, hand hygiene, wearing your masks, and hopefully the vaccination going on.
Do you have any more information on like research that's coming out on the new vaccines and the antibodies and all the things that are being injected into people these days?
That's a very big question. You want to answer? No. I can answer you briefly, just to give you an overview in the next 3 to 4 minutes. What we are injecting inside people's bodies comes in 2 forms. One are called the therapeutics. Those are done to treat a viral infection. And then the vaccines, which are given to prevent vaccine infections or to prevent the severity of the infection. Now, vaccines first, as you know, there's been a lot of press. Right now, there are only 3 vaccines which have got emergency use authorization. Emergency use authorization means that in a limited amount of study and follow-up, the efficacy has been demonstrated and relative safety have been demonstrated. And the efficacy and safety defined by the FDA before approval is considered a 50% protection from COVID infection or severe infection, and at least 5 to 6 patients in the placebo group should have died from COVID. In other words, you're not picking the healthiest people who don't even die and vaccinating them. So if you meet these 2 criteria, then the safety and efficacy standard has been met. So far, 3 vaccines have met those safety and efficacy standards. Number 1 was the Pfizer, which 10th of December 2020, the New England Journal paper, where you can see here It is one of the most dramatic graphs in medicine. This is also the Pfizer-BioNTech vaccine. That's the vaccine, which is a mRNA vaccine. That means a small snippet of the nuclear medicine has been now, it has been put inside an particle which is engineered. It's a little lipid particle and introduced into the body, which then causes severe immune reaction. And because the signature of the virus is similar to that snippet of the nucleic acid, so anytime the virus then enters, your immune system kills it because now it's ready. The whole reason it's spreading all over the world is because our body has never seen something like this. But with the vaccine, they would be primed and they'll kill it. And this graph, as you can see, is one of the most dramatic graphs in medicine. As you can see, it starts separating out very early in day 12. And the line, which is the red line, is a flat line. There is not a severe or moderate to severe COVID in people who got vaccinated. Whereas the people who did not get vaccinated, is the blue line, is an exponential growth, which has still not been controlled so far. The Moderna vaccine, which was published on the 30th of December, 2020, had almost identical results. It is the same technology and it has identical results. The fatigue, pain is a little different, but the nuances are indistinguishable from each other. The only difference is that the booster dose of Pfizer has to be taken in 3 weeks. The booster dose of Moderna has to be taken in 28 days. Now, just now on the 10th of January, the Johnson & Johnson also came out with their result, but this was not a phase 3 study. Johnson & Johnson was phase 1 and 2 study. The advantage of Johnson & Johnson is that it is, even with a single dose, starting from day 29, it has about a 72% protection rate of neutralizing antibodies. With the caveat that the South African variant, which is the B1315 variant, the efficacy was only 52%. It was not 71%. So that's a little concern that the newer mutation may not be as well covered by this vaccine. But the advantage of a vaccine is even single dose gives you a protection which lasts for more than 71 days. And there was almost 100% neutralizing bodies at about 57 days. So it has a tremendous promise, and they have, because Johnson & Johnson is such a big country, they've already promised to give more than 20 million doses. So we can cover the population so much and so fast, because the vaccination effort to reduce the COVID will only work if we develop a herd immunity, which means 60 to 70% of the world population has to be vaccinated. It makes no sense if 2 colonies vaccinate and the third colony doesn't, because then the transmission will be till perpetuity. And that will mutate, and the newer forms of vaccine, COVID will come, which will then make the vaccine ineffective. So these are the 3 vaccines in the United States which are approved. Now, since there are hosts from India, there are 2 vaccines that have been approved there, the Covishield and the Covaxin. Covishield is adenovirus. Instead of the little lipid, they use the nuclear medicine in an adenovirus and got it into the body, which was made by the Serum Institute of India. It's also called the AstraZeneca Oxford vaccine. And that has shown a 71% efficacy rate in less than 3 weeks. They had a second cohort, which has to get another dose in day 14, the results of which has not been published, so we don't know. The Covaxin was made by the Bharat Serum Institute with the National Institute of Virology and sponsored by the Indian Council of Medical Research, is also a vaccine, but that is different. It's a live attenuated virus. This virus, that means the COVID virus, has been destroyed to the point that it cannot replicate inside, but retains its signature. And if that is injected, they have given an efficacy rate of about 65%. Now, 65 and 70, it's not a race, because the US vaccines are showing 95% doesn't mean that they are more effective. It's just that the assay, the way you study the population and the tests that you've used are different. It's not standardized, as you say. The world was taken by surprise. So there's not an international standardization that you're comparing. It's not even comparing apples to oranges. It's apples to orangutans, actually. So you have to be very careful when you look at that number. They are very effective. And they have also received emergency use authorization in India and now being exported to 82 other countries. So clearly there's a significant benefit. So that's about the vaccine. Now the therapeutics, there are only 2 monoclonal antibodies. One is the Regeneron mixed antibody and one is the bamlanimab. Those are to reduce the severity of the disease, not curative. And those are used, one in the pre-hospital phase, and there's a very new medicine called the baricitinib that has been used for severe COVID for decreasing mortality and decreasing time on ventilators. What is that? Yes, can persons or biologics as Remicade, Humira, etc. take J&J vaccine as it is live? Firstly, the J&J vaccine is an attenuated adenovirus. The actual vaccine is a part of the RNA. It's not a full live form. We don't have any data that I can make this recommendation whether it can be taken if you have Remicade and Humira. So you're better off till we have more data to go into the Pfizer and the Moderna vaccine, then take the J&J at this time. But I'm sure they'll publish that data, in which case we can make those recommendations.
I think we are running out of time here. So,
Any other questions?
There was one about, is there any gene therapy such as CRISPR or any other kind of genetic therapies on the horizon that might help reverse the impact of coronary heart disease on the South Asian population specifically?
There are a lot of studies going on. The CRISPR technology, as you know, it's a newer technology, and some of the disease processes like the sickle cell disease and the macular degeneration and some of the other inheritable diseases, you've been able to modify the genes and put in exons and introns in such a place that the deficient mutated element of the gene has been removed. That's a tremendously powerful tool in the hands of the geneticists these days. It has not been done in heart disease, although gene therapy has been tried in peripheral vascular disease, but there was a sentinel event. One boy died, and as a result, the FDA has put a tremendous damper on it. But I think it's coming back again with the newer successes in some of the other disease processes. So yes, in the next 5 to 10 years, you will start up CRISPR technology and other genetic modification technologies being brought to bear on this scourge of coronary artery disease and heart disease.
Another question was, does cardiac arrest result in neurological dysfunction?
Yeah, you take that.
So cardiac arrest essentially what means that your pump has stopped, and the pump, which is your heart, is supposed to be delivering blood to all your organ systems, most importantly your brain. So yes, when the brain is deprived of oxygen because the heart is just not able to pump anything forward, you can result in irreversible neurological injury. And so that's another reason why, especially if the inciting event was a heart attack, it's so important to revascularize and get to the hospital in a timely fashion to prevent that. But yeah, 3 minutes of your heart being down can be enough to cause irreversible damage.
There's a few questions also, I think 2 specific cases about the COVID vaccine and procedures. One with a valve procedure and another for a pod surgery. Do you have any advice for COVID vaccines and planned like medical procedures?
Depending on the medical procedure, if it's an urgent or an emergent medical procedure, there's nothing in the vaccination protocol that prevents you from getting that. Having said that, the vaccination itself can cause some side effects, and you don't want to be suffering from some side effects when you're going through another surgery. Right. Okay. If your condition can wait, then just finish your second dose and then you can go for surgery. That also adds to the benefit that all of you are scared going to the hospitals, which is the place most likely to catch COVID. And if you're vaccinated, then you have the lesser chance of getting it. So doing it electively, finishing your 2 doses of vaccination would be probably the most prudent thing to do. But at the same time, if you have a condition which is time sensitive, urgent or semi-urgent, then don't wait for the vaccination to finish, because there is no contraindication to having surgery if you're getting vaccinated. The only thing is, if you're going for a mammogram, be careful with the vaccination, because in 40% of the patients, the lymph node in your axilla will swell up as a result of the vaccination, and the mammogram will read it differently, and that will start unnecessary procedures on you. So if you have a mammogram planned, then you better do it after several weeks of the vaccination.
I have a question. Does alcohol impact the effectiveness of the vaccine?
No, there is no data to suggest. When I say alcohol, I'm talking about mild to moderation. Now, if it's binge drinking and an alcoholic, that's a different thing, because alcoholics have a very reduced immune system. They have cirrhotic physiology, and the robust immune response of the immunity wouldn't be there. Alcohol itself reduces immunity a little, but if you stick to what Priya said, if you go to just 11 ounces of beer, 5 ounces of wine, and 1.5 ounces of spirit, that's not going to affect your immune response to the vaccine, and I think you are pretty safe to take it.
Doctor, my question was more like the recommendation in India seems to be that alcohol is a no-no, even moderate drinking is no-no during the vaccine period, like 3 weeks or 4 weeks after the vaccination. And Europe seems to be somewhere in the middle, and the United States seems to be that there's no recommendation at all, that they seem to say it's okay. I'm only talking about moderate drinking, not binge.
Yeah. All of you are trained in India. My old professor used to say, if you have 3 answers to one question, that tells me that you do not know the answer to the question. So clearly that's the case here. We don't have data to support. But again, I think it's done in good faith. The whole reason you're taking vaccine is that you get a robust immune response so that you're protected, and you want to get the bang for the buck for the pain that you're taking for the vaccine and even the risk, because these vaccines are emergency use authorization. So why would you attenuate that effect by taking alcohol or non-steroidal anti-inflammatory agents or any other therapy which can even dent it by 1%? Why would you do that? Why wouldn't you get the maximum bang for the buck? So you can use your common sense. Alcohol is known to reduce the immune system, and if you can avoid it and doesn't give you too much grief, then sure, go for it. But you will be a miserable camper not drinking, then I guess you should take it.
Carol, some more questions?
Oh, there was one. I know that Dr. Sen talked about Asian people being at a different risk factor for heart disease, but the question was, are there different kind of subgroups for cardiovascular risk within the Asian geographic regions?
I mean, as far as the literature that I looked at, it's sort of a novel thing even to separate South Asians from the Asian community in general, and that's part of the reason why it wasn't recognized till in the last, maybe 5-7 years, that South Asians themselves are at increased risk because they were lumped with East Asians and all this, and we are a disparate group of people. As far as looking at different communities within India, I'm not quite as sure, but obviously dietary differences do exist. Some people are more vegetarian, and because of that, their reliance on carbs is much more, and therefore their insulin resistance is more. So I think a lot of that has to do probably more with the nurture concept rather than what genetics they had. This might be a broad generalization, but I'm not so sure that within India, the genetics are necessarily as much to play in terms of different states as are the lifestyle choices made.
Well, I was going to say thank you so much, Dr. Kar. Thank you so much, Priyanka. Absolute pleasure and a wealth of knowledge I think all of us have got. This full session has been recorded and will be shared with all the members. I know there are more questions, so please keep them in the chat. We'll try to get back to you on an email with the answers. Perhaps we'll request Priyanka to help us out with that. But with that, Dr. Kar, very nice to see you, and thank you so much. Wealth of knowledge and understanding. Thank you. From all of us at Samudra Club.
And good luck and stay safe. Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you very much, guys.
Thank you.
Thank you so much.
Well, thank you, everybody.
Thank you.
This was